Sorry for the delay, friend. We have Professor Khanna sir, Professor Subaya sir. I expect Dr. Chintamani sir to join us shortly. Thanks for both the students for joining us this evening. Dr. Meghna is kindly contributed by Dr. Anandi ma'am and Gayatri ma'am from Stanley Medical College. Dr. Vaina Chakravarti is kindly contributed by Professor Arulappa sir and Professor C.D. Narayanan sir from Sri Ramchandra Medical College. Today I have very eminent faculty, Professor Subaya sir from the head of the oncology at Government Roypeta Hospital in RCC. And we have Professor Ajay Khanna sir, our senior faculty. And I could see Dr. Others are expected to join. And I apologize for the delay in starting up this program for about 7 or 8 minutes. So we have the first presentation of the next secondaries. So faculty, kindly take over. Chakravarti, you're good to go, ma. Please introduce yourself, tell about your unit chief, head of the department, and start your presentation.
Good evening, everyone. Today I'll be presenting a case of neck swelling. I am Chakravarti, final year PG from Sri Ramchandra Medical College. My unit chief is Professor Arulappan T, and the head of the department is Professor C.D. Narayanan. Sir, can I start, sir?
Yes, ma. Please start.
Presenting a case of a 65-year-old male who came, who's a farmer by occupation, hailing from Villipuram, who came with complaints of swelling in the left side of his neck for the past 6 months. History of presenting illness: the patient was apparently normal till 6 months back when he noticed a swelling in the left lower neck, which was insidious in onset, gradually progressive in size, initially 2 cross 2 centimeters, and progressed to the current size of about 5 cross 4 centimeters. The swelling is not associated with pain. The patient gives no history of evening rise of temperature, night sweats, or cough. No history of oral ulcers, loose tooth, halitosis, or difficulty in mouth opening. No history of hoarseness of voice or any voice change. No history of ear pain. No history of difficulty swallowing. No history of breathing difficulty or hemoptysis. No history of hematemesis, bleeding, PR, abdominal distension, or altered bowel habits. No history of loss of appetite or loss of weight. No history of swellings elsewhere in the body. No history of similar swellings in the past. Past history: patient is not a known case of type 2 diabetes, systemic hypertension, bronchial asthma, CKD, or CAD. No history of TB in the past. No history of radiation exposure to neck and head and neck in the past. Family history: no history of malignancy in the family. No history of tuberculosis in the family. Personal history: patient is not a known consumer of alcohol, tobacco, cigarettes, or bida. He has normal and bladder habits, normal sleep, consumes mixed diet. In summary, this 65-year-old male with a painless progressive swelling in the left lower neck with no other positive history. This is possibly cervical lymph node swelling. Sir, do I proceed with the examination?
One moment, ma. One moment. Khanna sir? Subaya sir? No, Kirit Parmar is also here.
So, what is your thinking now?
Sir, I am considering a possible cervical lymph node, sir.
Lymph node is there for everyone, you know.
Enlarged cervical lymph node, sir.
So, scientifically, how will you say?
Pardon me, sir?
Scientifically, how will you say? Enlarged cervical lymph node. Cervical lymphadenopathy.
Lymphadenopathy, sir. Cervical lymphadenopathy.
Okay, what is the positive history? Except
Sir, other than swelling, patient has no other positive history, sir.
Left lower neck.
Yes, sir.
Why not lipoma?
Sir, it could be, sir. One of the differential diagnosis could be a lipoma, sir.
Duration?
6 months, sir.
Okay. Why not a sebaceous cyst?
Sir, sebaceous cyst patient will have on and off, could have on and off symptoms of exacerbation of the cyst, which you could get infected. This is a painless progressive swelling, sir.
Okay.
It could be lower down on the differential, sir.
Any other swelling differential diagnosis in the left lower neck?
Sir, it could, if it is a midline swelling, it can be even a dermoid cyst, sir.
What is the occupation?
Zenkel diverticulum, sir.
Okay, proceed. Okay, proceed. You can proceed.
I'll proceed with the examination, sir.
Yes.
Thank you, sir. On examination, the patient was examined in a well-lit room after obtaining consent and exposing the patient till the waist. Patient is conscious, oriented to time, place, and person. Patient is moderately built and nourished. ECOG score of 0, Karnofsky score of 90. Pulse is 86 in the right radial artery, normal in rate, rhythm, volume, and character. BP is 120/70 in the right upper arm in sitting position. Respiratory rate is 18 per minute, abdominothoracic in nature. No pallor, icterus, clumping cyanosis, generalized lymphadenopathy, or pitting pedal edema. This is a clinical photo of the swelling, sir. A patient was examined in the sitting position from the front. A single ovoid swelling, horizontally lying ovoid swelling of approximately 6 cross 4 centimeters in the lower one-third of the neck with well-defined border, smooth surface. Skin over the swelling appears normal in the anterior triangle of the neck, left anterior triangle of the neck. Extent appears to be 2 centimeters inferior to thyroid cartilage, 2 centimeters superior to the middle third of clavicle, 4 centimeters from the 4 centimeters from the midline, and lateral extent is deep to the sternocleidomastoid. The swelling becomes less prominent on contraction of the sternocleidomastoid. It does not move with deglutition or protrusion of tongue. No visible scars, sinuses, or dilated veins over the swelling. No visible pulsations. Trachea appears to be in midline. No signs suggestive of Horner syndrome. On palpation, all inspective findings were confirmed. Patient was examined in the sitting position from the behind. A single ovoid swelling in the left anterior triangle of neck measuring 6 cross 4 centimeters with smooth surface and well-defined borders. Firm in consistency noted. Skin over the swelling is principal. The swelling is fixed to underlying structures. No intrinsic mobility is present. Swelling lies in a plane deep to the sternocleidomastoid. Trachea confirmed to be in the midline. Carotid pulsations are not displaced. No other swellings are palpable in the neck, left supraclavicular fossa or axilla. Examination, other systems, thyroid, normal, no palpable nodules. Cranial nerve examination, all cranial nerve functions are intact. Scalp, no palpable swellings. Oral cavity examination is normal, adequate mouth opening, poor oral hygiene, dental caries plus. No visible ulcers. Tonsils appear normal, no deviation of uvula, no induration, no loose dentition. Per abdomen, soft, non-tender, no palpable organomegaly. CVS, S1, S2, heard, no murmurs. RS, bilateral air entry, no added sounds. CNS, no focal neurological deficit. External genitalia is normal. Both bilateral testes are palpable. In summary, is a 65-year-old male with no known comorbidities who presented with a painless progressive swelling in the anterior triangle of the neck on the left side for the past 6 months. On examination, a solitary oval swelling in the level 4 region of the left with smooth surface, well-defined borders, and firm in consistency. My primary diagnosis is left level floor lymph node, lymphadenopathy, probably malignant in etiology, with a clinically undetected primary.
Hello, please.
No, why do you say it is level?
Sir?
Why do you say it is level 4?
It was lying just above the clavicle, sir, below the level of thyroid cartilage, sir.
Oh, below the level of thyroid cartilage. Just above. What is the distance from the clavicle?
Sir, about 2 centimeters above the clavicle, sir.
What is the landmark dividing level 3 and level 4?
Sir, cricoid cartilage, sir.
Okay. So, you exclusively, the whole mass is below the cricoid cartilage, is it?
Yes, sir. Almost the whole mass was below the cricoid cartilage, extending laterally below the sternocleidomastoid, sir.
Oh, the problem is you said the mass is 6 into 4 centimeter, you know.
Yeah, horizontally placed, sir.
Horizontally 6 centimeter, vertically 4 centimeter. Is it?
Yes, sir.
Okay, whatever it is, even 4 centimeter, it will spill over to level 3.
Level. Okay, sir. Yes, sir.
So just we should need to check it. Okay.
Okay, sir.
We need to check it. And did you check laryngeal crepitus?
Pardon me, sir?
Laryngeal crepitus.
Sir, no, laryngeal crepitus was present, sir.
How will you check?
Placing the stethoscope over the anterior part of the neck, sir.
Oh, laryngeal crepitus is we just try to move.
Move the larynx, yes, sir. On both sides, it should be mobile in both directions.
No, it will be mobile. Usually, normal individual, there will be a click will be there.
Okay, sir.
That click will be, that is rubbing the laryngeal apparatus over the prevertebral fascia and muscles.
Okay, sir.
That click will be absent if there is a mass
Laryngeal
behind
carcinoma.
no, just hear me. If there is a mass behind the larynx,
Okay, sir.
placed in between prevertebral fascia and larynx,
Okay, sir.
then that will be absent
Okay, sir.
because the rub will be prevented.
Okay, sir.
So, what is the organ that is behind the larynx? Hypopharynx. And
Hypopharynx. Hypopharynx.
Hypopharynx. Substrate may be postcricoid. So, laryngeal crepitus present or absent is important in level 3 and level 4 nodal swelling because
Okay,
they are the primary drainage area.
Yes, sir.
What is your diagnosis, clinical diagnosis? No?
Sir, it's level 4 lymphadenopathy with a clinically undetected primary, sir.
So, it is malignant, you say. Is it?
Yes, sir.
Why do you say it is malignant?
Sir, one is the duration of the swelling, sir. Second is the swelling is firm in consistency. Third is age of the patient, sir. Fourth is it's a painless swelling, sir.
Why not tuberculosis?
Sir, tuberculosis, the age does not, it's 56-year-old male, sir. So age is not this one. Even duration of swelling, 6 months, painless swelling, sir.
Who said 56-year-old man should not have TB lymphadenitis?
Sir, possible, sir, but my primary would be possibly this one, sir.
My point is, you may be correct. Why do you say it is malignancy, not infective etiology? Acute infection ruled out because
Yes,
pain is not there, fever is not there. That I agree. Why not a chronic infection like this one, tuberculosis, or a primary malignancy of lymph node lymphoma? Why
sir, lymphoma and tuberculosis would be part of my differential diagnosis, sir.
Okay. Then how will you differentiate? Clinically, how will you differentiate?
For differentiating from primary malignancy of the lymph node, we have to examine other lymph node stations, sir. Other lymph node stations will usually be involved, sir. If we are suspecting Hodgkin's, we even do parabdomen where we'll have hepatosplenomegaly, sir.
No, first differentiate between benign and malignant. That is tuberculosis and malignancy. How will you differentiate clinically?
Fixity, sir.
Huh?
Fixity, sir. The swelling that the patient that presented to me had swelling fixed to the underlying structure, sir. Tuberculosis usually not be fixed to underlying structure, sir. Second is tuberculosis has a propensity of involvement of the overlying skin also, sir.
Not necessarily,
So what is typical appearance of tuberculous lymphadenopathy and lymphoma lymphadenopathy?
Matted lymph nodes will be present in tubercular lymphadenopathy, sir. This is a single lymph node swelling, sir.
The anterior triangle, posterior triangle?
Posterior triangle usually in tubercular lymphadenopathy.
In your case, it is on
anterior triangle, sir. This is anterior triangle swelling, sir.
Okay.
Okay, what are the boundaries of anti-triangle?
Sir, midline, in the midline of neck, sir. Inferiorly clavicle, superiorly angle of mandible, posteriorly sternocleidomastoid, sir.
Repeat again.
Midline, sternocleidomastoid, inferiorly clavicle, superiorly angle of mandible, sir.
Which border of sternocleidomastoid? Anterior, posterior?
Posterior border of sternocleidomastoid, sir.
Triangle is
posterior border or anterior border?
Anterior border of sternocleidomastoid.
And how it is divided?
Pardon me, sir?
How it is divided?
It is divided further into multiple triangles by the strap muscles, sir.
By strap muscles.
What
are the strap muscles? Tell me.
By digastric, posterior, anterior belly of digastric and omohyoid is divided into further carotid and other triangles.
Specific.
Yes, sir.
This is PG clinic, huh?
Yes, sir. By anterior belly of digastric and omohyoid, it is further divided. Anterior triangle is further divided. Posterior
divided into
the submandibular triangle, carotid triangle, and
then
Sir, carotid. Muscular triangle.
Then submental triangle.
Submental.
Hmm?
Yes, sir. Submental,
Submental triangle.
muscular and carotid, sir.
So your swelling is present in which triangle? On anterior aspect of neck or on the submandibular area, submental area?
Anterior aspect of neck in the lower region of neck, sir.
Laterally, medially?
Laterally, sir.
Laterally. Because you have mentioned that swelling does not move on deglutition.
Yes, sir.
So what is your diagnosis by your history?
Sir, history, it is my initial diagnosis, keeping the age of the patient and duration, would be a probable cervical lymphadenopathy secondary to malignancy, sir.
What are the point to say?
Malignancy, sir.
No, point to say, you are telling that it is malignant. Now, what are the point in favor of malignancy?
Sir, painless swelling, sir. Duration of swelling, sir. Fixity to the lower
Please
structure.
go to the first side. Please go to the first side.
Sir, it's a painless swelling, age of the patient, duration of the swelling, sir. Fixity to lower structure, sir.
History wise.
History wise, painless duration, sir, and age of patient.
So your patient chief complaint is the only swelling in the left
Lower
side of the neck from last
Yes.
6 months.
Yes, sir.
So how will you exclude a different conditions or negative history?
Sir,
You're supposed to ask to exclude condition because there is for PG exam or for undergraduate exam also there is no marks for diagnosis. What they are testing, how you are different, they are take the negative history or what are the differential you are keeping in the mind. That
Yes,
is more important.
yes, sir.
Pertaining to the swelling in the lower part of the neck, how will you exclude the history? Tell me.
Sir, in swelling in the lower part of neck, to rule out tuberculosis, I asked for evening rise of temperature, night sweats, and cough.
Okay.
Then I went for ruling out any other primary sources. So I asked for any oral ulcers, loose tooth halitosis to rule out any oral ulcers as the malignancy as the primary, sir. Then also I asked for softness of voice or voice change to rule out laryngeal carcinoma, sir. I also asked for ear pain or hearing loss to rule out Rotter's triad, sir.
Why ear pain?
Sir, referred pain by trigeminal nerve, sir. Same supplies to the ear, so it will be referred pain to the ear, sir. If involvement of this one is the Rotter's triad, sir.
Okay. Then next.
Then I also asked for a history of any difficulty in swallowing or dysphagia for ruling out any esophageal lesions, sir. I also asked for history of any breathing difficulty, hemoptysis to rule out any primary in the lungs, sir. Also, I asked for to rule out, since the swelling is on the left side in the lower aspect of neck, by history, I had to rule out even any lower GI, any GI cancer. So I asked for hematemesis, bleeding, PR, abdominal distension, or ordered bowel habits, sir. I also for if there was any other swelling present in the neck or anywhere else in the body, sir, to rule out if it is any sort of lymphoma, sir, with other multiple lymphadenopathy.
So which different conditions you have excluded by this history?
Sir, I have excluded I have not entirely excluded tuberculosis, but history-wise, because of the absence of evening rise of temperature and night sweats, TB has been excluded, sir. I have also excluded primaries from the mouth, oropharynx, nasopharynx, and hypopharynx, sir. I have also ruled out primaries from the GIT or other primaries from the aerodigestive tract, sir.
Okay.
I have also ruled out other primaries from the esophagus, sir.
Okay. Come to the local examination then. Start present again.
A patient was examined in the sitting position from the front. A single ovoid swelling of approximately 6 cross 4 centimeters in the lower 1/3 of neck with well-defined borders. Smooth surface skin over swelling appears to be normal, noted in the anterior triangle of the neck. The extent of the swelling is 2 centimeters inferior to thyroid cartilage, 2 centimeters superior to the middle third of clavicle, 4 centimeters from midline, and laterally extending deep to sternocleidomastoid. Swelling becomes less prominent on contraction of the sternocleidomastoid, does not move with deglutition or protrusion of tongue.
What does this signify? What does this signify?
Which, sir?
Swelling becomes less prominent on
Sir, a
contraction.
plane of swelling, sir. It is not superficial. With this, I can rule out a lipoma or a sebaceous
So
cyst.
how you demonstrate it? Tell me just.
Sir, I will ask the patient to, on the opposite side, I will keep my hand and ask the patient to push towards that, sir, which will contract the sternocleidomastoid on the side that I'm examining, sir. And we'll see if the swelling becomes more prominent or less prominent, sir.
Okay. Then you have mentioned that swelling does not worsen on deglutition
Yes, sir.
and protrusion of tongue.
Yes.
Why protrusion of tongue is required in this laterally placed swelling?
Sir, in case if the
Why
swelling
it is required? It is not required
okay, sir.
because swelling is in the midline, laterally placed.
Lateral.
Protrusion of the tongue is seen in a
Midline swelling.
swelling.
Yes, sir.
Hmm? So tell me why thyroid gland moves with deglutition?
Because of the fascia that covers the thyroid gland is attached to the larynx, sir. So when deglutition, movement of the laryngeal aperture will also cause the thyroid gland to move, sir.
Okay. Then you have mentioned that the swelling moves on protrusion of the tongue.
Yeah, does not move, sir. Yes, sir.
So which swelling moves on protrusion of tongue?
Thyroglossal cyst, sir.
So what is the commonest position of the thyroglossal cyst?
Hyoid, sir, at the level of the hyoid bone, sir. At the level of the hyoid bone, sir.
Sometimes it is in which condition or in some few percentage of the patient it may shifted to one side. What is that site? Most common site of shifted thyroglossal cyst. Do you know?
No, sir, not
Always
first.
it is in midline.
Yes, sir.
But sometimes it is shifted to at one side, which is that level. At which level it will shift?
Not
Common
first.
question. Okay, proceed. Next.
No visible scars, sinuses, or dilated veins over the swelling. No visible pulsations. Trachea appears to be in midline. No signs suggest syndrome. On palpation, all inspectory findings were confirmed. Patient was examined in the sitting position from the behind. Ovoid swelling in the left anterior triangle of neck measuring 6 cross 4 centimeters with smooth surface, well-defined borders and firm in consistency was
Why
noted.
patient is examined in from behind?
Sir, ideally for examination of neck or thyroid or even lymph nodes in the neck, if we are sitting in front of the patient and examining, the patient might have a aversion because we will be extending our arm from the front towards the neck of the
Usually
patient.
examination of from behind is for thyroid swelling. Whole of the thyroid gland is examined from behind.
Yes, sir.
Palpation of the thyroid, whole of the, that is classical method, standard or conventional method. You have to stand behind the patient.
Yes, sir.
Then you have to keep both thumb on over the occiput and forefinger over the gland.
Yes, sir.
This is for the
Thyroid.
thyroid gland, not for the swelling. Lower lymph node swelling. That is not required to sit behind and examine it.
Okay, sir.
Okay, next.
Skin over the swelling is pinchable. It is fixed to underlying structures. There is no intrinsic mobility. Swelling lies in the plane deep to sternocleidomastoid. Trachea confirmed to be in the midline. Carotid pulsations are not distressed. No other swellings palpable in the neck, left supraclavicular fossa or axilla.
Where we have to palpate the carotid pulsation?
Sir, at the level of thyroid cartilage, sir. C6
Against
over the
which bone?
sir, over C6, sir.
Against which bone?
C6.
Which part? Body shaft, transverse process.
Transverse process of C6.
Tubercle.
Sir, transverse process of C6, sir.
Okay. Then?
On palpation for the thyroid was normal, no palpable nodules. Cranial nerve examination, all cranial
This
nerve.
normal thyroid is palpable?
No, sir.
Okay.
Cranial nerve examination, all cranial nerve functions are intact.
So which cranial nerve you have examined?
Sir, mainly hypoglossal nerve we have to check for, sir.
So how do you test hypoglossal nerve?
A deviation of tongue to the unaffected side, sir. To the affected side, sir. Unaffected side.
Okay. Any other
sir?
cranial nerve we need to examine?
Sir, vagus nerve also needs to be examined, sir.
Which nerve?
Vagus.
Okay. Okay.
Scalp, no palpable swellings, oral cavity, adequate mouth opening, poor oral hygiene plus, dental caries plus, no visible ulcers, tonsils appear normal, no deviation of uvula, no induration present, no loose dentition.
Hmm.
Uh,
So,
Sir,
okay, continue.
per abdomen, soft, non-tender, no palpable organomegaly. CVS S1, S2 heard, no murmurs. RS bilateral entry plus no added sounds. CNS, no focal neurological deficit. External genitalia examination is normal.
Okay. Don't mention such short forms, CNS, RF, ND. These are
Okay.
not standard.
Okay, sir.
So what is your diagnosis?
Sir, my diagnosis is a level 4, left level 4 lymphadenopathy, probably malignant in etiology. AJCC 8th stage, 8th edition staging N2A with a clinically undetected primary, sir.
Any other diagnosis you want to?
A differential diagnosis, I would also like to rule out TB lymphadenopathy, sir. Also lymphoma, sir.
Lymphoma.
Lower, much lower.
இன்னைக்கு ஸ்டவ் தூக்கி தொடச்சேன் கீழே.
Hello.
Yes, sir.
Other diagnosis is lymphoma.
Sir, I would like to rule out TB lymphadenopathy and lymphoma, but my primary working diagnosis will be level 4 cervical lymphadenopathy
Secondaries is neck with occult primary.
with unknown, clinically undetected primary, sir.
How will you investigate this patient?
Sir, initially I would.
Diagnosis. Why not it is HIV? HIV related lymphadenopathy.
That HIV related lymphadenopathy will also present with multiple enlarged lymph nodes, sir, generalized lymphadenopathy. But here there is no other palpable lymph nodes anywhere else, sir.
Any other point?
The patient also has no history of loss of weight, loss of appetite, no history of any
Hello.
Yes, sir.
Okay. So how will you investigate this case?
Sir, initially I would like to do an ultrasound of the swelling, sir, to confirm if it is a single node or there are multiple nodes, to check for the vascularity of the node, sir. Also to check for the consistency of the node, sir. I would also then like to proceed with the guided FNAC of the lymph node, sir,
Okay.
to establish my diagnosis as a malignant lymphadenopathy.
Okay.
Then I would like to do investigate for the primary, sir. Investigation for the primary will consist of pan endoscopy, sir.
Pan endoscopy, very good.
Then I would also like to examine the. I would also like to do an ultrasound neck to rule out any thyroid swelling, sir. I would also like to do a complete examination of the GI system to rule out any. If pan endoscopy is normal, sir, if there is no findings on pan endoscopy, then I would proceed with an ultrasound of the neck to rule out a thyroid, a primary as a thyroid. I would also like to examine the abdomen, ultrasound abdomen to rule out any primaries from the abdomen, sir.
Which thyroid malignancy is present like this?
Papillary carcinoma of thyroid, sir.
Okay. Any other investigation?
Sir, earlier blind biopsy used to be considered, but now blind biopsy is no more done for detection of the primary, sir.
Then how will you manage this case?
Sir, I would first like to look at the FNAC report, sir. The FNAC report, it will.
Suppose FNAC is lymphoma.
Sir, if FNAC is lymphoma, then patient will not require surgery, sir. Patient will benefit from chemotherapy, R-CHOP regimen, sir.
So what will be the stage?
Oh, so I'm not sure, sir.
Okay. Okay. How will you manage it? Suppose it is lymphoma, how will you manage it?
Sir, patient requires medical oncology. I will ask the medical oncologist to get involved, sir. Patient will require chemotherapy, sir.
So which regime?
R-CHOP regimen, sir.
No.
What is histological features of lymphoma?
If I can intervene,
Yes,
number
sir.
one, if the FNAC result shows lymphoma, then it's not enough. Okay.
Yes.
Lymphoma, you can suspect and diagnose with FNAC,
Okay,
but
sir.
definitive diagnosis of lymphoma.
Excision biopsy.
No, wait. Definitive diagnosis of lymphoma, and if it is NHL subtyping, requires a larger core of biopsy.
Okay, sir.
Either ideally full lymph node is ideal, but
Okay,
here you said this patient is having 6 into 4 centimeter size node,
yes, sir.
excision of which may not be that easy. So
Yes,
you can do true cut biopsy. And once the true cut biopsy confirms lymphoma, you should find out whether it is Hodgkin's or non-Hodgkin's.
Okay,
If it
sir.
is non-Hodgkin's, then you should do immunohistochemistry and whether marker studies. And once the diagnosis and subtyping of lymphoma will complete, you should stage the disease.
Yes, sir.
In any malignancy, the investigation will be number one, first diagnosis, number two, to
Staging.
stage, number two, to assess the patient for whatever treatment you are planning, and number four, if there is any requirement of post-treatment rehabilitation, that investigation you can do. So you should proceed on that way. You cannot jump once the FNAC is lymphoma, you cannot jump to give R-CHOP. R-CHOP is for non-Hodgkin's. What is the regimen you give for Hodgkin's lymphoma? And will you do to PET-CT or not?
Yes, sir. We'll proceed.
All this is, so that's my point is, when you are given a diagnosis, don't jump to okay?
Okay, sir.
Okay, the other examiner can take over.
What is histological features of the lymphoma?
Sir, sheet of blue cells, sir.
Hodgkin's
Altered
lymphoma,
NC ratio.
histological type or characteristic features.
Sir, orphan ani nucleus, altered NC ratio, presence of nucleoli.
Orphan anion nucleus in lymphoma
Hodgkin's lymphoma, sir.
or papillary carcinoma of thyroid.
Sorry, papillary carcinoma of thyroid, sir. The papillary carcinoma of thyroid, sir.
And Ristenberg cells, giant cells are seen in
Hodgkin's lymphoma, sir.
And what are the stages of lymphoma?
There are 4 stages, sir. Stage 1 will be only involvement of lymph nodes, a single group of lymph nodes.
Single lymph node group. Okay.
Single lymph node above the diaphragm. Stage 2 will be multiple lymph nodes above the diaphragm. Stage 3 will be involvement of lymph nodes both above and below.
Sorry. Wait. Stage 1 is single lymph node group.
Above
Stage
diaphragm.
It is not related to diaphragm.
Okay, sir.
Single lymph node group.
Okay, sir.
Stage 2,
Multiple lymph
lymph
nodes.
node on the same side of the diaphragm.
Okay, sir.
Stage 3.
On both multiple lymph nodes on both sides of the diaphragm.
And stage 4.
Organ involved.
Multiple extranodal sites.
External. Yes, sir.
What is the meaning of group A and group B?
Sir, that is based on the B symptoms, sir. Presence of B symptoms. Group A is absence of B symptoms. Group B is with the presence of B symptoms, sir. B symptoms are fever, night sweats.
Any other?
Weight loss, sir.
Unexplained fever, weight loss, and night sweats.
Night sweats.
And how will you manage this? Suppose this is Hodgkin's lymphoma, how will you manage this?
Sir, for
Stage 1 Hodgkin's lymphoma, how will you manage this?
sir,
What is the investigation protocol? Suppose this is stage 1 Hodgkin's lymphoma. What is the investigation protocol? How will you investigate this case?
sir, I would first like to stage the disease, sir, for which I would proceed with the PET-CT, sir. To stage the disease, sir. Then following which I would, if the disease is stage 1, I would plan appropriate chemotherapy, sir.
The role of ultrasonography of abdomen or CT abdomen.
Sir, yes, sir, to rule out extranodal disease, sir.
What is histological types of the Hodgkin's lymphoma?
Sir,
Histological types.
lymphocyte rich, lymphocyte depleted, nodular sclerosing,
Mixed cellular.
mixed cellularity.
Which is having most favorable prognosis?
Nodular sclerosing, sir.
No.
Sir,
Lymphocyte predominance.
lymphocyte rich,
And worst prognosis unfavorable in a lymphocyte
depleted.
depletion. So which regime how will you manage? What is the treatment? For stage 1 disease, stage 2, stage 3. Which regime you will use?
Sir, R-CHOP is a non-Hodgkin's.
Hmm?
I'm not sure, sir.
Regime for Hodgkin's lymphoma.
I'm not sure, sir.
MOP regime, CHOP regime,
R-CHOP,
ABVD.
R-CHOP regimen AVBD.
What is the A stand for?
Adriamycin.
Hmm.
V is vincristine. Bleo,
Blastin.
vinblastine, bleofuscimide, and
When to give and how to give. What is that protocol? You know this, all these points?
no,
Because
sir.
all these are very important.
Okay, sir.
For secondaries in neck or any lymph node swelling of neck, Biova will go anywhere from lymphoma, malignancy, HIV, even oral malignancy. What is the protocol of follow-up in case of Hodgkin's lymphoma? Do you know?
No, sir.
Why not it is cervical rib?
Sir?
Why not it is cervical rib?
I didn't get you, sir. Sorry, sir.
Why not it is a cervical rib?
Sir, cervical rib will be hard, sir. And when we do an X-ray and an ultrasound, we will be able to differentiate from a cervical rib, sir.
Why not it is carotid body tumor?
Sir, carotid body tumor will have expansile pulsation, sir. Whereas there is no pulsations over the swelling over here, sir.
Any other peculiarities of carotid body tumor?
Will you say carotid body tumor in lower neck?
No, sir. It will come at the bifurcation of carotid, sir.
Where is the bifurcation?
Okay. So, what is the site, exact site?
Level of thyroid cartilage, sir.
Upper
C4,
border,
sir.
upper border or lower border?
Upper border, sir.
Then why do you say accepted for carotid body tumor? See, examiner will lead you to anything. Why you accepted carotid body tumor?
Yes, sir. Sorry, sir.
You said you said the swelling is in the region of level 4 lymph nodal Gruyere region.
Yes, sir.
Okay. Level 1 is above the digastric, above the head. Okay.
Yes, sir.
Level 2 is digastric to the cricoid cartilage or the place where the omohead crosses the sternomastoid underneath.
Yes, sir.
Level 4 is below and in front of omohead.
Yes, sir.
Level 5 is posterior triangle.
Posterior.
When you commit yourself to level 5 swelling, cervical rib, okay. Why do you accept for carotid body tumor?
Yes, sir.
Cannot, you know.
Yes, sir.
If there is a suggestion, you should say, sir, carotid body is the least possible thing by any imagination because swelling is in the lower neck.
Yes, sir.
If it is in the level of level 2 area, then where is carotid body?
Sir, upper border of C4, sir.
No, where is carotid body?
Bifurcation of carotids.
Bifurcation or around the internal carotid artery?
Yeah, around the internal carotid artery, sir.
Okay, so you should not accept. Here, okay, the FNAC comes as thyroid malignancy. How will you proceed?
Thyroid malignancy, sir.
FNAC comes as thyroid malignancy. How will you proceed?
Sir, in that case, I would like to do an if the FNAC comes as thyroid malignancy, I'd like to do an ultrasound of the neck to confirm a primary in the.
You said, already. See, when you said ultrasound neck, the ultrasound neck is done to confirm whether it is nodal swelling or not.
Yes, sir.
Number 2, to rule out any other nodal region involvement.
Yes, sir.
Number 3, to rule out thyroid nodules. Okay.
Yes,
when will you do CT scan?
Sir, if I have a suspicion of fixity to underlying structures, sir.
That clinically you can elicit,
Yes, sir.
Fixity to underlying structure, clinically you can elicit.
Sir, if there is any retrosternal extension, sir.
Okay. If it is or you suspect unusual nodes involvement.
Yes, sir.
Okay, now let me know. So thyroid, you said in your investigation, there were no thyroid nodules.
Yes, sir.
Clinical examination.
Yes, sir.
So now it comes as thyroid carcinoma as deposit. How will you proceed?
Sir, if it is thyroid carcinoma, most likely it will be papillary carcinoma of thyroid, sir. I would like to proceed with surgery, sir. Total thyroidectomy plus modified radical neck dissection of the left.
What type of nodule?
Type 3, sir. But that will again depend on what structures are involved, sir. On if the lymph nodal mass is not adherent to the.
What about central compartment nodal dissection?
Pardon me, sir.
What about central compartmental nodal dissection? You should do,
yes,
once the lateral nodes are involved.
Yes, sir.
You should do the central compartment nodal dissection also.
Yes, sir.
So the treatment will be total thyroidectomy, central compartment nodal dissection, and modified nodal radical neck dissection type 1, 2, 3, whatever feasible.
Yes, sir.
Okay. How will you follow up after treatment? Surgery?
After surgery, follow-up will be with thyroglobulin, sir. So initially, I would like after the surgery, I would like to plan the patient for a radioiodine scan, sir. Sir, to look for any remnant tissue or any other metastasis, sir. So I would I initially like, sir.
Tell me.
I would initially like to do an I-123 radioiodine scan, sir. If there is any presence of any remnant tissue on that, then I would proceed with an I-131 radio ablation of the remnant thyroid tissue or metastasis, sir.
No, already is a huge nodal metastasis,
Yes, sir.
Won't you do adjuvant I-131 ablation?
Yeah. Yes, sir. We can go with adjuvant. We can go. We can not without doing the radioiodine scan. We can go with the radioiodine straight upfront low dose radioiodine ablation, sir.
What is the prerequisite for radioactive ablation? You can do immediately, is it?
No, sir. The TSH has to be more than 30, sir. Thyroid hormone supplementation has to be stopped for about 6 weeks, sir. TSH should be more than 30, sir. Following which only we can proceed with the radioactive ablation, sir.
Okay. What is the alternative for withholding L-traxin?
Recombinant TSH. If the patient is not tolerant, we can use recombinant TSH, sir.
Okay. How will you follow up the patient after treatment?
Sir, follow-up of the patient will be with TSH, sir. As papillary carcinoma of thyroid is a TSH-dependent tumor, based on the risk of the patient, we'll have to follow the patient with the TSH. We'll have to give the patient a suppressive dose of L-troxin, sir, which will be tailored based on the risk of the patient. In
this patient, how much you will sir?
Sir, this patient will come as a moderate. I'm not
There are,
sure.
there are only two, high risk and low intermediate.
Low risk, sir. Yes, sir.
Okay.
I'm not,
Okay.
sir. This
Okay.
patient will come as a high risk, sir, because
Okay.
patient presented with nodal metastasis. So I like to maintain the TSH below 0.1, sir.
Okay. If the second FNAC comes as squamous carcinomatous deposit,
Sir, if the FNAC comes as squamous cell carcinoma, then I would like to go for investigation of the primary, sir, which should initially start with a pan endoscopy, sir, in which I will
everything done. You have done CT scan.
Sir, PET CT. If the PET CT is also normal, then we'll have to go in for PET CT is normal. We can go in for a neck dissection, sir.
You said 6 into 4 centimeter.
Yes, sir.
What is the end stage?
Sir, it comes as N2, sir.
6 centimeter. Okay.
3 to 6 centimeters is N2, sir.
Okay. So what's the? It's okay. If feasible, you can do radical neck dissection.
Yes, sir.
But this particular individual is presenting with level 4 nodes.
Yes, sir.
What is the guarantee that there is no microscopic disease in the superior mediastinum?
Sir, when we do a PET CT, we will be able to see if there is any active disease, sir. If not, we will proceed with the radical neck dissection at present, sir. Following which the primary will keep the patient on close follow-up to watch for presentation of the primary, sir.
The stage group N2 that belongs to in TNMC. N2.
Not sure, sir.
N2 belongs to either stage 3 or stage 4,
Okay, sir.
That is managed with multimodality management.
Okay, sir.
So you need to give adjuvant radiation at any cost.
Okay, sir.
So why not upfront chemoradiation, which will include, because your surgery is not going to include the possible primary sites.
Yes, sir.
That is hypopharynx.
Yes, sir.
Why don't you treat with chemoradiation and tackle the residual disease if there is you can tackle it. That also you can do,
Yes, sir.
What is the age of patient?
65 years old, sir.
65. 65 is still more a reason,
Yes,
He's
sir.
an elderly man. Smoker or not smoker?
Non-smoker, sir.
Okay, he's an elderly man with some comorbidity?
No comorbidities, sir.
Okay, even then, you can treat with chemoradiation and tackle the residual disease later on.
Yes, sir. We can go with neoadjuvant radiotherapy followed by residual disease 6.
Okay, I am done. Anil sir, from my side, the examination is over. Can I go in?
Shall we move to next place, sir?
We can, sir.
Manal, you please unshare your screen, ma.
Thank you, sir.
Questions do you have, ma, to ask the faculty to clarify?
Sir, the examination of neck for neck nodes also should be done only from the front, sir, not from the back, sir.
Yeah.
Okay, sir.
It depends. Inspection definitely from the front. Palpation, either it is moving or not moving, it is prudent you tell that you examine from the back. But there are very huge lymph nodes on the lateral side and other things need not be taken into that category. Any front part of the neck, any thing attached to the thyroid or a in contiguity with thyroid, it has to be essentially felt from behind,
Okay.
right? So that makes your perception better, and many of the things which are missed in the inspection can also come to a limelight better when you examine from behind. More of sensory perception.
Okay, sir. Thank you, sir.
Faculty, any other comments, please?
No, sir. He has covered most of it.
Yes, sir.
answered well.
Yes, sir. Thank you very much, Chakra. And then I give my regards to Professor Arlappa sir and Professor C.D. Narayanan sir. Thank you for joining this evening. You can stay back for the next case discussion also.
Thank you very much, sir.
Friends, we have the second. Yes, ma'am. Friends, we have the second case discussion by Dr. Meghna. Meghna is a postgraduate from Government Stanley Medical College Hospital. So, Meghna, please switch on your video, share your PowerPoint.
Good evening to all the respected faculty.
So, yes, sir, Saravanan sir, Kanna sir, please take over, sir. Thank you. Please go ahead, ma'am. Please introduce yourself and start your presentation. Nishi sir, please take care.
Good evening to all the examiners present today. I'm Dr. Meghna, postgraduate from Government Stanley Medical College, Chennai. My chief, Dr. Anandi ma'am, and under the guidance of my HOD ma'am, Dr. SP Gayatri ma'am. So I'm going to be presenting a case on carcinoma penis today. So Mr. M, a 65-year-old male, resident of Chennai, a daily wage worker by occupation, presented with the ulcer over the penis for 6 months. Patient was apparently normal 6 months back, after which he presented an ulcer over the preputial skin, which initially started as an ulcer, later progressed to a growth of about 2 centimeter, insidious in onset and progressive in nature, not associated with pain, not associated with discharge. Patient has no history of hematuria or burning maturation, no history of trauma, no history of loss of weight or appetite, no history of high-risk sexual behavior, no history of cough, hemoptysis or dyspnea, no history of jaundice, or no history of bone pain. Past history, patient is a known hypertensive for 4 years on regular medications, not a known case of diabetic cardiac disorder or renal disorder, no history of previous surgeries. Personal history, patient consumes mixed diet, patient has normal sleep and appetite, normal bowel and bladder habits. Patient is a known smoker and alcoholic for 20 years. For the past 2 months, he's been abstinent. Family history, nil significant. So, by summary, my patient is a 65-year-old male, chronic smoker, presented with ulcer over the preputial skin for 6 months with no pain or discharge.
Hello. So what is your possible diagnosis?
So my first diagnosis would be probably a carcinoma, because the patient said he has an ulcer which which progressed into a growth over the past 6 months.
What is ulcer by definition, madam?
Sorry, sir?
What is ulcer by definition?
Sir, ulcer is a discontinuity in the epithelium, sir.
Complete definition. What is ulcer by definition?
An ulcer is a discontinuity in the epithelium.
No.
Yes, sir.
Ulcer is the break in the continuity of the skin or mucous membrane along with the molecular death. That is complete definition of ulcer.
Okay,
Then
sir.
what is wound? Then what is wound?
Sir?
What is wound then? What is definition of wound?
So wound can be even deeper in.
I want definition. I don't want explanation.
Yes, sir.
Wound is a break in the continuity of the skin without molecular death.
Okay, sir.
And you have mentioned that there is a growth. Huh?
Yes, sir.
In your history,
Yes, sir.
did you ask for any history of difficulty in retracting the skin back?
Yes, sir. I asked, sir, but patient has a freely retractable foreskin, sir.
No, you didn't tell, that's right.
Yes, sir.
Because what are the pre-malignant predisposing factors for cancer penis?
So it can be pre-malignant lesions of penis can be HPV related or non-HPV related, sir. So BXO, balanitis erotica obliterans, is non-HPV related pre-malignant lesion, sir. So which can cause difficulty in retraction of the foreskin, and other HPV related Pre-malignant lesions include chordyloma acuminata, Bowen's disease, and genital warts, and other carcinoma. I mean, in situ lesions like erythroplasia, Buschke-Lowenstein tumor, sir. And other non-HPV related include cutaneous horn and pseudoepitheliomatous mycaceous keratosis, sir.
Okay. You can proceed.
Proceed, sir. Yes, sir. On examination, after obtaining verbal consent, patient was examined in a well-lit room. Patient was conscious oriented, moderately built and nourished, belongs to ECOG 0 and well hydrated. On vitals, temperature afebrile, pulse rate 86 per minute, measured in the right radial artery, regular in volume, rhythm, character. Blood pressure 130/80 millimeter mercury in the measured in the right brachial artery in sitting position. Saturation 99% on room air. Respiratory rate is 18 per minute. No pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy or pedal edema. On local examination, a single ulceroproliferative lesion of size 3x2 centimeter over the preputial skin with irregular margins, everted edges. Floor is covered with slough. Surrounding skin was normal, no dilated veins, cause sinuses. The glans and penile shaft looks normal. External urethral meatus is normal and scrotal appears normal. On palpation, a single ulceroproliferative lesion of size 3x2 centimeter over the preputial skin with irregular margins, everted edges, base is covered with slough and indurated just below the lesion, not warm or tender, does not bleed on touch, and preputial skin is retractable. The glans and penile shaft and urethra are normal on palpation. Bilateral testis and scrotum are normal. On examination of the bilateral inguinal region, on the right side, a single swelling of size 1x1 centimeter, firm in consistency with smooth, well-defined margins, mobile, which is non-tender or warm. Left inguinal region is normal on palpation. This is the image of the patient. On systemic examination, S1, S2 heard, no murmurs. On respiratory examination, bilateral normal recycled breath sounds heard. CNS examination, no focal neurological deficit. In per abdomen is soft, non-tender, no organomegaly, bowel sounds are present. On digital rectal examination, there is normal air in tone, no prostatomegaly, no mucosal irregularities or palpable nodules. Glove stained by normal stools. Case summary: 65-year-old male, chronic smoker and alcoholic, with an ulcer over the preputial skin. On examination, an ulceroproliferative lesion over the preputial skin of 3x2 centimeter, irregular margins, everted edges, floor covered by slough, indurated, with right inguinal lymphadenopathy, which is mobile, non-tender, with no obvious clinical distant or organ metastasis. So my provisional diagnosis would be a clinical T1N1 lesion. Carcinoma penis or preputial skin, sir.
How will you investigate this case, madam?
Sir, first we would like to do an ultrasound, sir. High frequency ultrasound can tell us about the depth of the tumor. Also, ultrasound of the bilateral inguinal region to look for other subcentimetric lymph nodes, sir. And further, we need to take a biopsy of the lesion and send it for histopathological examination to look for the type of tumor and grade of the tumor, sir.
Madam, what are differential?
What type of biopsy will you do?
Ulcer over the penis. What are differential diagnosis of ulcer over the penis?
Sir, ulcers, even in sexually transmitted diseases, there can be ulcers, sir. For example, in lymphogranuloma venereum or in a chancre or syphilitic ulcers also can cause an ulcerative lesion, sir. And in certain autoimmune conditions also can cause genital ulcers, sir.
Okay.
What will be the appearance in tuberculous ulcer?
So tuberculous ulcer, the edges usually will be undermined with floor is covered usually by slough, sir, and there will be usually a discharge, sir.
Why there is undermined edges are seen in tuberculosis, madam?
Sir, tuberculosis usually has affinity to the subcutaneous tissues, sir. Mycobacteria has affinity to the subcutaneous tissue, hence it usually erodes in the subcutaneous area, sir.
How will you clinically test it?
So you
No,
can
no, no.
this
What will be the histopathology in tuberculosis ulcer? What is the histopathological picture? What happens to the vessels?
so there'll be granuloma, sir.
Okay.
Caseous granuloma, sir.
Regarding the vessels,
So
you have
vessels, sir.
obliterative endarteritis.
Yes, sir.
Obliterative endarteritis is causes ischemia and necrosis. And the
Yes.
necrosis affects mostly the subcutaneous tissue because
Okay,
it
sir.
has more ulcer. So there will
Okay,
be
sir.
overhanging edges, undermined ulcers. Okay.
Okay, sir.
Fine. Any other differential diagnosis? You said the sexually transmitted diseases.
Yes, sir.
Which sexually transmitted disease produces similar type of ulcer?
So usually painless ulcers are common in syphilis, sir, but otherwise even lymphogranuloma venereum caused by chlamydia is also a cause of painless ulcers, sir.
Usually in primary syphilis, the ulcer is mostly unnoticed. It usually disappears.
Yes, sir.
Granuloma inguinal can produce painful ulcers. It
Yes, sir.
produces ulcers, but it will be very painful,
Painful. Yes,
hard
sir.
and painful ulcer, and bleeds are touch.
Yes, sir.
Okay. So lymphogranuloma is one difference because you have a node with the ulcer. It is
Okay, sir.
common in LPD.
Yes, sir.
What is etiology for CA penis, madam?
Sir, sorry, sir.
Etiology for CA penis.
Sir, most commonly it's a HPV related carcinoma, sir. Uh, Risk factors also include a patient who is not circumcised at the neonatal age group, with promiscuous sexual activity, high risk sexual behavior, and patient even smoking has an indication for risk factor, sir.
So what is the ideal age for circumcision?
So the neonatal
Prevent the
circumcision.
malignancy.
Neonatal
Prevent the
circumcision.
malignancy.
Sorry, sir.
What is the ideal age for circumcision to prevent malignancy?
Yes, sir. Neonatal circumcision is proven to prevent malignancy, sir. Anything after the neonatal age group has no change in the rate of incidence of carcinoma, sir.
Yeah. Okay. So, what are the serotypes of HPV which cause CAPs?
Sir, most commonly it's the 16 and 18, sir. But otherwise, we also have 31, 33, 50, 52, and 58, sir.
Do you know the oncogenesis of how HPV causes?
Yes, sir.
CAPs?
Actually, proto-oncogenes E6 and E7 are present, sir, which causes the regulation of P53 and retinoblastoma genes, sir, which in turn causes upregulation of P16, which causes cell apoptosis and necrosis, sir. Be- yes, sir. Because of the downregulation of P16, there is overactivity, sir, and hence there is yes, sir.
What are the other pre-malignant causes apart from papilloma? What are the other pre-malignant causes? Pre-malignant lesions.
Yes, Belanite erotica obliterans is one, sir.
What is that? BXO?
BXO, it's a chronic inflammatory change, sir, that causes usually stricture of the preputial skin, also sometimes associated with urethral stricture, sir.
Mainly starts with meatal stenosis,
Yes,
and because of high pressure voiding, the Litters gland get infected, produces
yes,
urethritis and urethral stricture.
yes, sir.
Okay.
Yes, sir.
So, any bacteria which is implicated?
Yes, sir. Probably it's Borrelia burgdorferi is supposedly involved, sir.
Supposedly, but not proven.
Yes, sir. Not proven completely. Yes, sir.
What will be the histopathological picture in BXO?
Sir, chronic inflammatory changes, sir, with no specific.
There will be no specific infection. There will be loss of retipex,
Okay, sir.
loss of retipex and acanthosis. Okay.
Okay, sir.
So, picture to another condition which is called what? Another condition which is similar to BXO. which can also occur in females. Lichen sclerosis.
Yes, sir.
Lichen sclerosis
Yes.
yet atrophic,
Yes, sir.
which can also affect the vagina in
Yes.
postmenopausal woman.
Yes,
Loss of
sir.
estrogen, it produces lichen sclerosis and atrophic.
Yes,
It's
sir.
the vagina.
Yes, sir.
So this is also pre-malignancy.
Yes, sir.
Does leukoplekia produce malignancy? Is a pre-malignant lesion? Leukoplekia.
Yes, sir. Leukoplakia is a pre-malignant lesion, sir. Yes, sir.
What is erythroplasia of Poirot?
Sir, it is a reddish papules which occur usually on the glands of the penis, sir. It is thought of as a cutaneous manifestation of an underlying malignancy, sir.
It is a carcinoma in situ.
Yes, sir.
It is a
Carcinoma.
carcinoma in situ of glands.
Yes, sir.
If the same occurs in the shaft, it is known as
Bowen's disease, sir.
Bowen's disease. That's right. What is verrucous carcinoma?
So varicose carcinoma usually is a type of good prognosis, a type of commercial carcinoma that has a good prognosis, sir. Usually has a varicose type of warty cauliflower-like growth, sir.
What is the peculiarity of verrucous carcinoma? It doesn't produce much.
Sir, it doesn't have any underlying invasive or lymphatic invasion or yes, sir.
Distal metastasis. Okay,
Yes,
it's very
distal
rare.
metastasis.
And it doesn't respond to what? Radiotherapy.
Radiotherapy,
Surgery
sir.
is the treatment of choice.
Yes, sir.
Okay, you can proceed. So,
Yes.
what biopsy you are going to do for this patient?
So usually incisional biopsy, sir, from the edge of the tumor.
No, here the tumor is involving only the prepuce, isn't it?
Yes, sir.
Incisional biopsy or which biopsy?
Sorry, sir.
Which biopsy?
Incisional, sir.
Or which
But
biopsy?
here only prepuce is involved, no?
Yes,
Why
sir.
can't you totally remove the prepuce? Why don't you do a circumcision biopsy? Is it not possible here?
Yes, sir. Possible, sir.
Okay.
So that also you can do.
Yes, yes, sir.
If the tumor is involving the glands, then you do an incisional wedge biopsy,
Yes, sir.
involving normal tissue
Yeah.
as well as the ulcer.
Edge
That is
of
known as a wedge
the
biopsy.
growth. Yes, sir.
Edge of the ulcer. So if you take biopsy from the center of the ulcer, will it be useful?
No, sir, because usually there will be only necrotic tissue in the center. We would not get proper yield of the carcinomatic cells, sir.
Okay. The periphery has proliferative tissue.
Yes, sir.
So you said about imaging for assessing the depth of invasion.
Yes, sir.
Okay. Which imaging is very good to assess the depth of invasion?
Sir, MRI pelvis is mostly superior.
MRI penis is superior.
Yes, sir.
High
Yes, sir.
frequency ultrasound can give an indication.
Yes, sir.
The MRI is the best one.
Yes,
Clinical
sir.
examination you can clearly assess.
Yes, sir.
The extent of penetration can be clinically examined.
Yes, sir.
If you have a doubt about the extent of spread, or if your management is going to be altered by assessment of this thing, then MRI is warranted.
Yes, sir.
And regarding inguinal nodes, what is the best method for evaluation? One is clinical examination, then
Sir, usually CT is required, sir. But even
CT is the best one.
ultrasound, sir, sorry?
CT is the best one.
CT is the best one. Yes, sir.
So when do you want CT? For all cases, will you do CT scan?
No, sir. Usually, high grade primary tumor with more than 2 centimeter lesion, probably even if it is clinically, there is no node on clinical examination, it is better to go ahead with a CT scan to look for inguinal or even pelvic lymph nodes, sir.
So CT is indicated when clinical examination is not conclusive. You are not sure whether node is seen or not. Patient is obese,
Yes,
or
sir.
if there is any previous inguinal surgery done. When your examination is inconclusive, then CT is indicated. Or
Yes,
in
sir.
situations where the lesion is a high grade lesion, but still CT nodes are not probable, then we have to do a CT scan.
Yes, sir.
And other indication is to assess the pelvic nodes.
Yes,
So
sir.
to best method for evaluation of the pelvic nodes is by a CT scan.
CT scan, sir.
So for this patient, you have done a biopsy.
Yes, sir.
What was the biopsy report? What other investigations will you do apart from this? Any other investigations?
Before proceeding further,
Yes, sir.
can I ask, did you retract the skin and saw the distance between corona glandis and the lesion?
Yes, sir. Yes, sir.
Is it involving the underlying peripheral mucosa?
No, sir. Sir, it is only arising from the prepucial skin, sir.
Skin.
Yes,
So
sir.
when you retract, the underlying mucosa is not involved, is it?
No, sir.
Okay. Then my practically for this patient, both for biopsy purposes and for staging purposes, you can do upfront circumcision.
Yes, sir.
Like, there is a clinical doubt of malignancy,
Yes, sir.
and there is no harm in doing a complete circumcision,
Yes, sir.
and you can achieve clear margins by doing circumcision.
Yes, sir.
Then the simple thing, both biopsy and staging will be, instead of doing MRI and other costly investigations for this particular patient.
Yes,
Because
sir.
in the exam, we need to discuss about the patient we have at hand.
Yes, sir.
Unless the examiner is asking, okay, now the lesion is not like this, it is involving glands and all, then you can say MRI penis.
Okay, sir.
Here, this is a peculiar case, not often you get. The lesion is confined to prepucial skin. So a mere circumcision will solve all your problems of primary staging.
Yes,
Nodal
sir.
staging you can do. Nodal staging, you can do ultrasound. Ultrasound is a good investigation. And if you suspect iliac nodes, you can go for CT scan.
Yes, sir.
Otherwise, you said T1.
Yes, sir.
How will you stage cancer confined to prepucial skin as by T staging? How will you do? What is T staging? Can you enumerate?
So actually, T1 involves only the glands or prepuce, sir. With the T1A is without lymphovascular invasion. T1B is with lymphovascular invasion, sir. So usually it is a pathological staging only, sir.
Okay. T2?
T2 involves the corpora spongiosa, sir, and T3 involves the corpora cavernosa, and T4 involves the adjacent structures.
Okay. The latest staging you telling.
Yes, sir. There is no involvement of. I mean, there is no mention of urethra in the latest staging, sir.
So nodal staging in this particular patient?
So in this particular patient, it is N1, sir, clinically, because N1, as by definition, is a single mobile node, ipsilateral node, and N2 is usually multiple ipsilateral nodes or bilateral nodes, and N3 is either the extranodal extension or pelvic lymph nodes, sir.
Okay. So ultrasound confirms N1 node. What is the best staging procedure in this patient? Supracerebral dissection.
Yes, sir.
You can do supracerebral dissection, subject the specimen to frozen section. The frozen section reveals still a single node is involved. Then you can manage conservatively.
Okay, sir.
Here is a particular patient where you can be minimalistic.
Yes, sir.
If at all you want to do any investigation, you can do FNAC of the node.
Yes, sir.
That will give you information before surgery whether to do unilateral or bilateral.
Yes.
Opposite nodes are normal, is it?
Sir, by ultrasound, there was subcentimetric nodes on bilateral regions. Sir, right side, it was largest was 1.5 centimeters. Sir.
What is the probability of having nodes in T1 disease?
Sir, usually very low, sir. Like Less than 10.
That's the reason you should do FNAC here. If the FNAC is negative, even you can do intraoperatively excision biopsy also.
Yes, sir.
So T1, the probability of nodes are very low. And
Yes.
you it is confined to proteins.
Yes, sir.
Okay. If we are good
See,
discussing.
this is where, yeah. So, whether biopsy or resection is needed depends on the biopsy of the primary lesion. So, the biopsy of the primary lesion shows it is a grade 2 lesion.
Moderately
It's a grade 2
differentiated.
moderately differentiated
Yes.
squamous cell carcinoma, and they are not given about what we need. What else we need in this biopsy report? We need whether vascular invasion is seen.
Yes, sir.
Neurovascular invasion is present or not.
Yes, invasion. Yes,
Okay.
sir.
So grade 1, T1, G1, if there are nodes, we can give antibiotic, see whether they subside or not.
Yes, sir.
Then we can do a FNAC if nodes doesn't subside, and
After
then we
2
can
weeks.
proceed with
Yes,
blood
sir.
resection, superficial blood resection, and proceed with deep if
Frozen
superficial is
section.
positive.
Yes, sir.
Yeah, frozen. Suppose if it is G2 or G3, then it becomes a little bit higher risk. T1
Yes,
with the
sir.
G2, G3.
Yes,
Then
sir.
in these cases, we have to go for a superficial blood dissection.
Yes, sir.
So superficial blood dissection, if the superficial nodes are positive, then go for deep. Okay.
Yes, sir.
So always we go one level above. If the
Yes.
superficial positive, we go to deep. The
Deep,
deep is
yes.
positive, then we have to remove the pelvic.
Iliac. Yes, sir.
So you have to go one stage above and completely clear it. So in this case, because it is grade 2, I think it is better to go for a superficial blood dissection on both sides, and depending upon the biopsy report, we can go for further dissection or we can follow up. If these
Yes.
next nodes are negative, then we can follow up. Okay.
Yes.
What are the morbidities of nodal dissection, inguinal nodal dissection?
Sir, most common issue is a seroma formation or a flap necrosis. Further, lymphedema of the limb and lymphoria, sir. These are the most common and morbid complications, sir.
Predominantly, it is seroma and flap morbidity.
Yes, sir.
When will you do ilioinguinal dissection?
Sir, when we have a positive lymph nodes in the inguinal region, sir, it's better to go for a ilioinguinal dissection, sir. Clinically or pathologically positive inguinal nodes, it is better to go for iliac, a higher stage in iliac dissection, sir.
What are the boundaries of your inguinal dissection?
Sir, superiorly we have the inguinal ligament, sir. This is actually called Dressler's quadrangle, sir. So laterally we have a 20 centimeter line drawn from the ASIS downwards, and medially we have a line drawn from the pubic tubercle 15 centimeter downwards, and a line joining these, sir. And superiorly, inguinal ligament is the boundary, and then inferiorly fossa ovalis, and laterally we do not go beyond the femoral artery, sir.
We're talking about
And medially,
So adductor longus is the boundary, sir.
you're talking about
adductor longus is
modification.
boundary.
You're talking about modification. Meghna, you're talking about modification or classical inguinal dissection?
Modification, sir.
I asked you what are the boundaries of classical superficial inguinal dissection.
Sir, superiorly it's the inguinal ligament, and laterally is the sartorius, and medially is the adductor longus, sir.
Sartorius which margin? And lateral or medial?
So adductor longus it's the lateral border, and sartorius it's the medial border, sir.
You are wrong. Sartorius is medial border, adductor longus again medial border.
Medial border. Okay, sir.
Usually we take some fibrofatty tissue from the anti-abdominal wall, few centimeter above the inguinal ligament also.
Okay, sir.
So deeper aspect.
So deep is usually below the facial aorta, sir, involving the
we are doing only
femoral cloquet node, sir.
So
Sorry, sir.
we are talking about only superficial inguinal dissection. We are not talking about lingual dissection. We are talking about superficial inguinal dissection.
Okay, sir.
What is the difference between superficial inguinal dissection and classic inguinal dissection? In classic inguinal dissection, you go deep to fascia lata.
Yes, sir.
Superficially, you don't disturb the fascia lata.
Fascia lata, yes, sir.
What are the modifications you know?
So Catalona modification is the most commonly used, sir.
What is the modification?
Sir, usually involves using a smaller incision and not removing the great saphenous vein, and there is no transposition of the sartorius muscle.
Is a smaller incision is a criteria?
Sorry, sir?
Is smaller incision is a criteria?
Yes, sir.
Yeah, I don't think so. Because you can do video endoscopically also, you know.
Okay, sir.
Okay. Okay, good. Dr. Saravan, you can proceed.
Yes, sir. So what is sentinel node biopsy? In which condition we will do a sentinel node biopsy?
Sir, if there is no clinically nodal disease, but there is a higher grade of tumor or higher stage, T stage of tumor, and it's better to do a sentinel lymph node biopsy and then further proceed with dissection, sir. So classically, it was described as the superomedial group was removed, but later there have been modifications using dyes, sir.
So you can inject a dye along with the radioacetone.
Technetium, yes, sir. Technetium 99 labeled colloids.
Labeled with collagen, iron colloidal injection.
Yes, sir.
So how do you group these inguinal nodes? What are the groups?
So actually, it's based on the GSV tributary entering into the femoral vein, sir. So the one around the saphenous opening is central, sir. The one then it's divided into superomedial, superolateral, inframedial, and infralateral, sir. Based on the tributaries of the.
What are the tributaries?
So superolateral is the circumflex vein, sir. Medial is the external pudendal, sir. Lateral is the lateral cutaneous femoral vein, and inframedial is the great saphenous vein, sir.
Okay.
Yes, sir.
Oh. So what will be a incision? What are the types of incision?
So there's usually either a horizontal or a vertical incision, sir. So or there can be even a lazy S-shaped incision, which is extended from the vertical incision, sir. So it is better to proceed with the vertical incision over the horizontal incision, sir. Sorry, sir. It's better to proceed with the oblique incision rather than the vertical incision.
Oblique incision preserves better blood supply.
Preserves better. Yes, sir. I'm sorry. Yes, sir. Preserves the blood supply, sir. Yes, sir.
So how do you follow up these patients?
So follow-up usually is the guidelines say 3 month follow-up for first 2 years, and then 6 months follow-up for the next 1 year, and 1 year follow-up for the next 5 years, sir. Including, clinical examination and radiological examination, sir.
Suppose if the patient develops pelvic nodes,
Okay, sir.
what would be a line of management?
So we'll have to radiotherapy or adjuvant chemotherapy, sir, post-operatively.
Okay. But if the nodes are mobile, operable, then you go for a excision.
Okay, sir.
You remove the nodes. If the nodes are fixed, then you have to do chemotherapy, radiotherapy. If the nodes are mobile, you first do a surgery, do
Okay,
a
sir.
complete node dissection, and subsequently you have to subject the patient for chemotherapy.
Okay, sir.
Suppose the nodes are inoperable, then you give a neogen chemotherapy,
Okay, sir.
and the nodes become operable, then do surgery.
Yes, sir.
Okay.
What are the boundaries of pelvic nodal dissection?
I'm not sure, sir.
It laterally genitofemoral nerve, proximally bifurcation of common iliac artery.
Okay, sir.
Distally, you take care, you are removing the deep nodes of plaquette, and
Yes.
medially it is operator now.
Okay, sir.
Usually we don't go below the operator now because lot of veins will be there and you will end up in troublesome bleeding.
Okay, sir.
Suppose this patient is not willing for surgery, what will you do?
This patient we can attempt uh, topical agents or
Meghna,
yes, sir.
don't get carried away by the examiner. If patient is not willing for surgery, convince the patient for surgery.
Okay, sir.
Yeah, you can cure by circumcision, you know. Many people undergo religious circumcision. You convince the patient for surgery. The examiner
Okay,
may
sir.
ask any question. A 60 years old man in a country like ours, 65 years. What is the functional morbidity he's going to have?
Yes, sir.
Convince. That's all. Simple.
Yes, sir.
No such thing like topical this and that.
Yes, sir.
Okay. Usually in exam, you should be confident,
Yes,
but
sir.
not be arrogant.
Yes, sir.
There is a mild threadbare difference.
Yes, sir.
You believe what you believe, you say politely.
Yes, sir.
Okay. If this patient is given to me, I will tell my examiner, sir, I will do only 2 investigations. Number 1, circumcision. Number 2, ultrasound angle region.
Yes,
That's
sir.
Circumcision is an investigation for me. It's both confirming the diagnosis and staging the disease.
Yes, sir.
That ends the matter. Okay. Congratulations. You did well.
Thank you, sir.
Thank you.
Thank you, sir.
Thank you.
Professor Kanagavel, you up to you.
Sorry, sir.
Professor Kanagavel?
Sir, I'm here, sir.
Okay, up to you. Both the candidates were good.
Yes, sir.
The first candidate was good in presentation, but when given the neck node, he should prepare a little bit well about.
Yes, sir. Yes, sir. Point is taken, sir.
And second patient is also good. Only thing is he should stick on to the hair belief, not to get carried away with it.
Stay strong with your points. Saravanan sir, would you like to give any comments?
She presented well, and but she has to be more confident about her discussion. That's
Yeah.
all.
Yes, sir. Yes, sir. Nishi sir, your view, sir?
Sir, both of them presented well, sir.
Very good, sir. Very good. So I would only wish the candidates to take down the areas where you are little weak or get stumped by the examiners. It's not getting stumped, but definitely there are always avenues to improve upon. Please take note of it, and by tonight or tomorrow, you finish reading that areas where you are not so very confident. And I recommend all of you to at least read once the NCCN recommendations of the respective cases what you present. The overview part at least, because there are a lot of algorithm based approach. Those part can be little later you can assimilate, but then the overview, it runs about 5 or 6 pages, the summary of how to manage the case. That helps you to face the examiner. See, the examiners are only trying to test whether you are strong at fundamentals and you are able to logically plan a treatment for the patient. That is the fundamental arrangement for a postgraduate clinical discussion. So, but then I would recommend you to go back to Campbell. That helps you to understand the carcinoma penis, because many questions, if you see the pre-malignant lesions, ifs and buts of many subtype management, all those things are well addressed in Campbell urology. Of course, the adjuvant therapies, the surgery part of it are very well discussed in DeVita. So it should be a combination of it. But I would recommend this CAPN is definitely, it's not that very well discussed in the basic surgery textbooks, where Sapiston or Bailey and other things. So I recommend you to go back to the subspecialty textbooks so that you are much more confident when you face the examiners. So, faculty, any other questions, sir? Can we call the session a close, sir?
Okay, you can close.
Yes, sir. Thank you, sir.